International Chapter of Mexico. Our moderators tonight are Dr. Samuel Chaba and Dr. Eduardo Montalvo. We asked all the speakers to keep their microphones on mute. We have tonight nearly 1,000 registrants. The SSAT was founded in 1960. Our mission is to lead in advancing the science and practice of gastrointestinal surgery. Our vision, to be a global community of GI surgeons advancing research, innovation, advocacy to the benefit of interdisciplinary patient care. We know that many of you may not be members, and we invite all of you to become members by coming to our website. In addition to the journal, you'll have access to scholarships and travel awards. Tonight we have a great lineup. After a few introductory remarks, we'll move right into 3 case presentations. One on pancreatic cancer, another on multifocal liver metastasis after colon cancer, and the third on the giant paraesophageal. The seminar will be recorded, so if you miss parts of it, you'll be able to go back to it. And again, we're delighted you're able to join us. We have an exciting program and world international experts on each of these topics to discuss them. With that, I'll turn it over to Dr. Montalvo.
Now it's your turn. Katsu.
Yes. Can you hear me?
Yeah, we are hearing you very well. Go ahead.
Good. Okay. Katsu Yanaga from Japan. Thank you for giving me an opportunity to give a remark. On behalf of the International Relations Committee of SSAT, I congratulate the first establishment of international chapters in Mexico and their organization of the inaugural global webinar today with Dr. Daniel Jones under the leadership of our President, Professor Mark Callery. I'm also delighted to know that the global webinar series will be scheduled regularly from now on and available to all SSAT members as well as non-members worldwide. With such international exchange of knowledge and experience, I'm convinced that SSAT will add more international flavors and diversity, which definitely will stimulate the establishment of many international chapters to follow Mexico. I look forward to the success of the first global webinar and the future webinars to come. Thank you for your attention.
¿Cómo hago para compartir la pantalla? Sí, pero no puedo acá. Somebody is...
Dr. Jones, can you stop sharing your screen so Dr. Montalvo can share his?
Screen, I cannot get access to that.
You should be okay now, Dr. Montalvo.
Okay, go ahead. Yeah, just... Okay. Hello, everyone. Welcome to this first webinar for the Mexican chapter of the SSAT. I will try to make my presentation in English and Spanish. My slides in English, and I will try to talk in Spanish and some keynotes or important points in English. So this is the first SSAT clinical case management webinar, and we organized this one. Nosotros hemos hecho un gran esfuerzo para organizar este primer evento como el primer webinar de la Asociación de Cirugía del Aparato Digestivo como parte del capítulo México, con la discusión de casos clínicos, uno sobre páncreas, uno sobre hígado y uno sobre hernias paraesofágicas. Les voy a contar brevemente cómo fue la creación del capítulo México. We have prepared a great scientific program based on the
Eduardo,
clinical cases.
Eduardo, tiene que lanzar la presentación. Está viéndose los slides siguientes. Lance la presentación.
Se está viendo los, a ver, what about now?
No, lo mismo. ¿Eso es Keynote o es PowerPoint?
It's PowerPoint.
Si es PowerPoint, busque el teloncito que está bien abajo y lance toda la presentación.
You have to unshare and then share again, but choose the different slide, the different projector.
What about now?
Ahora está bien, ahora sí.
Perfect.
Ahora sí.
Okay. Apologize for this inconvenience. Let me try to start how the Mexican chapter was created. Permitirme informarles cómo se creó el capítulo México. Hace más de 5 años, la inquietud después de estar más o menos 17 o 18 años como socio en la SSAT, con un grupo de cirujanos y un grupo de cirujanos dentro de la asociación, se decidió participar con muchos presidentes interesados en la difusión internacional de este evento. Y hemos preparado este evento con mucha dedicación y esfuerzo para poderlo compartir con todos ustedes. El capítulo México se lanzó oficialmente en el Congreso del año pasado en la Ciudad de México, de cirugía del aparato digestivo, en agosto del 2019. En esta foto pueden ver un grupo de destacados cirujanos, desde el doctor Jack Cameron hasta el grupo de profesores que encontramos aquí participando en este primer seminario o primer capítulo internacional. Este punto es muy importante. Aquí tenemos al doctor Callery, al doctor Nat Soper y al doctor Michael Sarr, expresidentes y presidente de la Asociación de Cirugía del Aparato Digestivo, cuando se hizo el lanzamiento del capítulo México. Hasta el momento, el capítulo México tiene 201 miembros y todos y cada uno de ustedes están cordialmente invitados a participar. This is the August 2019, when Mark Callery and the group of the former president of SSIT participate in our Congress here in Mexico City, and SSIT Mexican chapter was launched in August 2019. I know this year is quite difficult due to the pandemic, the COVID-19. Even that, and despite the SSIT Global Chapter in Mexico is now legally official. In July 15 of this year, a group of Mexican surgeons participated in this big effort. Ha sido un gran esfuerzo para el capítulo México la conformación de trabajos y la capitulación legal para llevar a cabo la instauración del capítulo México, y en julio 15 de este año se logró este gran objetivo a pesar de estar en un tiempo tan complicado como es el COVID. Aquí nos ven con unas cubrebocas y todos los cuidados necesarios para mantener la sana distancia, aunque en esta para la foto lo tuvimos que cambiar. Let me introduce the Board of Trustees of the SSIT Mexican Chapter. Permítanme presentarles la mesa directiva del capítulo México de la SSAT. El doctor Samuel Chuslev es el gobernador, es parte del board del SSIT. Su servidor como presidente, el doctor Samuel Klingfinger, es el vicepresidente, el doctor Enrique Stoppen es el secretario y Gabe Larcón es la tesorera. Todos ellos participan en este seminario. Tenemos diferentes comités. We have different committees in the Mexican Chapter: Scientific Committee, Education, Research, National and International Relations Committee, and the Ethical Committee too. This is Dr. Callery last year and during our Congress, and this a new partnership with SSIT and a group of Mexican surgeons. It's very important to the interaction with FILAC. What FILAC means is the Federation of Latin American Societies for Surgery. And one more thing is that we have access to many educational and research programs such as the JOGS. This is the official journal of the SSIT. Como parte del capítulo México tenemos una importante interacción desde el año pasado, cuando el presidente de la asociación, el doctor Caleri, anunció este nuevo capítulo. Una interacción muy importante, y agradezco al doctor Nathan Sultan presente en esta sesión, la interacción con FELAC, que es la Federación Latinoamericana de Asociaciones de Cirugía, y la opción es de participar en muchas actividades académicas y científicas, entre ellas la participación o la obtención de la revista de cirugía del aparato digestivo, que es el canal oficial. Tenemos también como parte de esta sesión al doctor Tim Public, quien es el editor de la revista, y muy importantemente va a favorecer el envío de publicaciones y de artículos para el grupo latinoamericano y de México. We have with us Dr. Tim Public, who is the co-editor of the Journal of JOGS. He will be very happy to receive all the papers, a manuscript from Latin America and Mexico. This is the Journal of Gastrointestinal Surgery. Esta es la revista científica de la asociación. Tiene un impacto de 3.5 y pueden enviar todos sus reportes y publicaciones o potenciales publicaciones, y se pueden incorporar estudios multicéntricos y reporte de casos. Pensar en cirugía, if we are thinking in surgery, I would like to use this slide from the last year here in Mexico, where Dr. Pellegrini, former president of SSIT. Pensar en cirugía siempre hay que tratar de ser proactivos y participar e interactuar en el punto de vista científico y académico. Es algo que queremos motivar en este nuevo capítulo y esta nueva interacción internacional. I would like to thank to many societies and associations here in Mexico. First of all, the Mexican Association of General Surgery and his president, Dr. Roberto Torres, AMCAT, Dr. Rodriguez Juan, National Academy of Surgery, Dr. Miguel Abdo, FILAC, Dr. Nathan Sulner, Dr. Olvera in Surgical Endoscopy, and Dr. Klingfinger at the College of the Surgeons of the Mexico City. Quiero agradecer a todas las asociaciones que ustedes pueden ver aquí presentes y a sus respectivos presidentes por la participación y colaboración en este primer capítulo. Also, I would like to thank all the Board of Trustees of the SSIT. The chair is Dr. Steven Stein. Thank you, Dr. Stein, for staying with us, and Dr. Caleri for your support, and Nicholas Bote as a vice president, and also Dr. Taylor Real, secretary of the society. We receive a lot of support from Stanley Ashley and Nat Soper, former president of this prestigious society. Quiero también agradecer a la mesa directiva de la SSAT, conformada, como ustedes pueden ver a su izquierda, por el grupo de destacados cirujanos que mencioné anteriormente, y también los antecedentes de cirujanos y presidentes previos que apoyaron mucho a la presentación y a la formación de este capítulo. Also, I would like to thank the International Relations Committee. The chair is Dr. Yanaga from Japan. We already know him very well. And the group of the members, this is the list in the bottom right of your screen. A la derecha de su pantalla pueden ver todo el grupo con que conforma el Comité de Relaciones Internacionales de la Asociación de Cirugía del Aparato Digestivo, encabezado por el que ya nos presentó el doctor Yanaga, y todos trabajan activamente. And finally, I would like to invite to everybody for the next meeting of the SSAT, hopefully no virtual, in Washington, D.C. next year. Finalmente quisiera invitarlos al próximo año al evento que se hace cada año con la Semana Quirúrgica y Digestiva, de enfermedades digestivas en Washington, D.C. en mayo del próximo año, esperando que sea presencial y no virtual, dependiendo de las condiciones actuales. I would like to thank to everybody for this webinar, and I would like to introduce Dr. Samuel Chuslet for his presentation. Quiero presentar al doctor Samuel Chuslet, quien es el gobernador de la SSAT de Capítulo México y un gran amigo, y que va a hacer presentación y sus palabras para todos ustedes. Muchísimas gracias. cabrón es eso en inglés en español.
Si no, ya dame la cámara. Sorry for the inconvenience. This is modernity that is not for so many of us. I'm going to speak in Spanish and you have the slide in English. I'm just going to take a couple minutes. Agradezco a ustedes nos permitan reconocer a algunos de los miembros de la SSAT, la Sociedad de Cirugía del Tracto Alimentario en los Estados Unidos, quienes gracias a ellos logramos la incorporación del primer capítulo de la sociedad fuera de los Estados Unidos de Norteamérica. La historia es breve. 5 años atrás, durante el final de la presidencia del doctor Fabricio Michelazzi y el inicio del doctor Nathaniel Sofer, y estando un servidor en funciones como director ejecutivo de la FELAC, platicamos largamente en la posibilidad de mejorar nuestras relaciones académicas. Se nos otorgaron facilidades especiales para todos aquellos cirujanos certificados miembros de la FELAC, para que nos incorporásemos como miembros del SSAT en una forma muy sencilla. Y un grupo muy numeroso de cirujanos mexicanos aprovechamos esta oportunidad, la cual sigue abierta para todos nuestros amigos latinoamericanos. Durante la presidencia de los profesores Stanley Ashley, Steven Stein y con el actual presidente Mark Callery, el capítulo mexicano fue aprobado y su anuncio oficial se llevó a cabo durante la inauguración del Congreso del AMCAD en la Ciudad de México en el mes de agosto de 2019, como ya lo mencionó Eduardo Montalvo. El anuncio oficial fue hecho por el doctor Callery y Eduardo Montalvo fue nombrado como su primer presidente. Nuestro agradecimiento a los miembros del board y especialmente a Daniel Jones, quien se ocupó de revisar los estatutos de dicha asociación y poder modificar lo necesario para incorporar capítulos extranjeros fuera de los Estados Unidos. Esperamos que la creación de nuestro capítulo abra las puertas para aquellos cirujanos interesados en México, así como el resto de Latinoamérica. Afortunadamente, el doctor Sundel se encuentra con nosotros, que es quien me sucedió como director ejecutivo, y estoy seguro que apoyará este movimiento que debe resultar en incorporar a mucha gente a tan prestigiosa sociedad. Juntos intercambiaremos opiniones académicas y finalmente se verán reflejados en beneficio de la salud de nuestros pacientes. Bienvenidos todos a los nuevos miembros del SSAT, en especial a todos los profesores participantes. Muchísimas gracias. Un anuncio final es que todos los miembros mexicanos del SSAT serán incorporados en forma automática como miembros de nuestro capítulo México, y en breve serán notificados de esta individualidad. Muchas gracias y esperamos que sea de beneficio para todos ustedes este webinar. Mark Callery le toca.
Thank you, Sam. And good evening, everyone. On behalf of the nearly 2,900 members around the world of the SSAT, we bring our goodwill, our gratitude, and our congratulations on pulling something off that we hope will be historical and certainly is going to be a milestone in the history of the SSAT. There's been enough thank you for those who are here, and folks are starting to get ready with their clinical cases. So I'll yield the floor to our first presenter, Dr. Carlos Chan, if that's okay with Dr. Dan Jones and Dr. Montalvo.
I will make the introduction for the first case. Hold on 1 second.
Este va a ser allá, que es Carlos Chan.
Charlie, Charlie. Voy a poner la pantalla.
No vimos ni más.
Okay, I would like to present the first case. And thank you to all the panelists and the case presentation for Dr. Carlos Chan. Dr. Chan is from the National Institute of Nutrition here in Mexico City. He's a HPV surgeon and former president of the HPV Mexican chapter of the American HPV Association. Doctor Carlos Chan, es un privilegio de la presentación que él va a hacer de todos los panelistas en el caso de cirugía pancreática. Como ya escucharon, él es del Instituto Nacional de Nutrición y expresidente de la Asociación Mexicana de Cirugía Hepato-Pancreato-Biliar y fundador de dicha asociación. Also, I would like to present to all 5 panelists. First of all, Dr. Tara Kent from Boston, Beth Israel Deaconess Medical Center. She is a HPV surgeon. Dr. Taylor Real from University of Arizona, Vice Chair of the Department of Surgery there in Tucson, Arizona, and SSIT Secretary. Dr. Charles Vollmer is a very good friend of us. He is a pancreatic surgeon, expert in research and translational procedures and a lot of pancreatic information, cutting edge for us. He was the former president of the American HPV Association. Mark Callery, our president of the SSIT, and Dr. Stephen Stein, he is the Board of Trustees chair from Albany Medical College in New York. Dr. Chan, please proceed to the pancreatic cancer presentation. Su micrófono, Charlie.
I'm sorry. Can you hear me now?
Sí, adelante.
Can you hear me?
Yes. Sí, adelante.
Thank you very much for this invitation. Thank you to SSAT, Mark Callery, Eduardo, and Dr. Shuslev for this complex organization for this webinar. I would like to present a very straightforward case without any specific difficulty for the diagnosis in order to facilitate the discussion between the panelists and to be very of benefit for all the audience, especially for residents and young people. Voy a hablar algo en inglés. Esta es una paciente femenina de 69 años de edad con un índice de masa corporal de 35 kilogramos, con un franco sobrepeso, una historia familiar de cáncer de colon que viene del papá y, bueno, niega historia de tabaquismo y alcoholismo. Una historia personal de hipertensión arterial, epilepsia bien controlada y una taquicardia, una arritmia bien controlada. Tiene una historia de 3 meses, dispepsia, llenado postprandial, ha perdido peso también, y 1 mes con ictericia y prurito generalizado. Las pruebas de función hepática con un patrón colesterol de los primeros días, después que llegó conmigo venían un poco más altas, pero con bilirrubina total casi de 6, aumento de fosfatasa alcalina, gamma glutamil y un CA19-9 de 34.9. So I would like to start the discussion with my friends. I hope all of them are here because I don't see them on the screen. Light about risk factors for pancreatic cancer. Remember that she's a lady with obesity and a family history of colon cancer. I would like to start with Dr. Stein, if he's there, to talk about just very in a short and quick manner the risk factors for pancreatic cancers.
Well, I think age is a risk factor. And I think that the woman has a indication to be screened based on the fact that she's jaundiced. You know, although that a CT scan is going to be what she eventually is going to require, I think it's still reasonable to start with an ultrasound to exclude a more easily treatable diagnosis such as choledocholithiasis. Although many people get CA19 early, my preference is to get that once you have the diagnosis, the presumptive diagnosis of pancreatic cancer.
Thank you. Now that you mentioned the CA19-9, I would like to ask Dr. Kent, so what is the role of CA19-9 for the diagnosis, or for what is it will be important, this antigen?
The CA19-9 I would not necessarily obtain as a pure screening test in patients presenting with jaundice without these other factors that you're discussing here today. But in a patient where there's a concern for malignancy, while it can be indicative of at least in part, the elevation relating to biliary obstruction, it certainly would raise my concern for a malignant process. And once malignancy is confirmed, a higher level of CA19-9 will increase my level of concern for metastatic disease, or even if not identified in imaging, then for occult metastatic disease.
Okay, so Dr. Callery, so who else should be screened for pancreatic cancer in general population? Who could be in risk for so high to need to be screened for this pathology?
Well, if more people were screened, it would mean that we have a good screening test. And as Dr. Kent mentioned, CA19-9 is really an after-the-fact event and really not a screening event such as mammograms would be for breast cancer. There is one other thing about this particular patient to emphasize as a risk factor, and that's her BMI. Obesity, there's good data to show that obesity is a risk factor for pancreatic ductal adenocarcinoma. Other groups are people who are surveilled for cystic disease of the pancreas, known mucinous lesions, people with hereditary pancreatic cancer risks, and some genetic subgroups that are pretty infrequent.
Yeah, thank you. Dr. Real, so who else should be screened in general? So patients with any specific disease or genetic condition that should be screened very early, even without symptoms, not in general population, but who specific population asymptomatic, but with what do you think, what risk factors for early screening or
so there are a few centers in the country that are doing screening in high-risk patients. You know, these would include patients who have 3 or more first-degree relatives with pancreatic cancer. And then certainly patients with certain genetic syndromes, for example, BRCA2 mutations, you know, in patients who've had breast cancer, we've had a lot of patients get pancreatic cancer as well. You know, as Dr. Callery mentioned, the screening tests we have are not good. So even in those high risk patients, they've not proven to be terribly effective as of yet.
Okay. So Dr. Horner, what would be then the best way to approach this 69 years old jaundice patient? What would be the best approach to start?
Is that directed at me?
No, to Dr. Ballmer.
Well, I think the next thing Dr. Spain brought up already was you have to sort of think out of the box. You're a pancreatic surgeon, HPV surgeon, but this may not be pancreatic cancer. So you need to work on stone disease and or a medical cause of jaundice like hepatitis. So you start with the appropriate lab test and an ultrasound for that. What you're likely going to find here is an ultrasound will show a dilated duct and hopefully without stone obstruction and a tapering point or some element to that. And it may or may not identify a mass. The next step beyond that would be a better axial imaging that is going to be more specific. I would like to say two things about previous comments. First of all, about the CA19-9, it is not proper or accurate to use this in a jaundice patient because it will be falsely elevated. So it's best obtained if you have relieved the jaundice preoperatively. And of course, its big use is actually for the medical oncologist in terms of recurrence follow-up. And then the other comment about the risk factors in screening is that even though a high-risk group can be screened, the actual discovery of adenocarcinoma in that enriched group is only 2%. And you are more likely to find either a neuroendocrine tumor or a pancreatic cyst through the screening process thereafter.
A manera de resumen, comento que el papel del CA19-9 no es útil como diagnóstico inicial, particularmente en pacientes con ictericia o que está obstruida la vía biliar, en donde puede dar un falso de mayor elevación. Los factores de riesgo en esta paciente, sin duda, la obesidad. Hay factores genéticos en pacientes que ameritan un tamizaje más temprano. Son los que deberían en un momento ser estudiados. Sin embargo, el cáncer del páncreas no es tan frecuente como para evitar un screening de toda la población. Están en general ellos todos a favor de un estudio de imagen. Un ultrasonido sin duda es de utilidad y bueno, es lo que finalmente se hizo, hacer un ultrasonido. As Dr. Stein mentioned, abdominal ultrasound is a good way to start any patient. Reveló este ultrasonido una dilatación de la vía biliar intra y extrahepática. So the question is, what's next? What study for you of imaging study would be the best way to start on? Just very quick, all of you, please. Who is in favor of a CT versus an MRI? Quick.
Callery. Favor a CTA.
Here we get an MRI.
MRI, why? Why, Dr. Rian?
Honestly, where I came from before, we got a good triple phase CT, and that was more than adequate. We have radiologists here who favor MRI, but I actually think either one is sufficient.
Anyone?
Yeah, I can't read MRIs alone as well as I can read CT scans, Carlos.
I prefer a CT scan because it's a lot easier for us to understand the tumor relations with vascular elements. I would prefer an MRI if I'm dealing with cyst disease that will be looking at the plumbing aspect. But here we want to look at the parenchyma and most importantly, the interface of tumor with vessels to properly stage it.
Yeah.
But I do think a good quality MRI can do that. We get them here all the time and get the same detail.
We have one for you as well. So Tara Kent, this is the arterial phase of the CT. So I'll go very slow so you can please mention what is relevant on this CT related to the arterial phase. Please, Tara.
Of course, in general, in considering whether a patient would be a surgical candidate, we also consider the baseline anatomy in terms of arterial variance, and then looking here for any involvement around the SMA or the celiac, or extending up along the common hepatic or gastroduodenal artery.
Do you see any involvement here? This is the
I
arterial.
don't.
Okay. Now let's see the venous phase. Let's go. I'm sorry. This is the. So, Dr. Stein, this is the venous phase. Can you comment something on this, please?
Well, I mean, the best I can tell, it looks like it is free of the vessels and is likely to be resectable without requiring a vein resection.
Dr. Cagliari, any comment on this?
Yeah, I'm sure the MRI will be needed to define what that tiny little thing is out at the left lateral section of the liver on some of these pictures. Whether it's a cyst or it could be something worse. I don't think it will be worse, but that would be my biggest prompt for an MRI. Right there.
I never saw this, but this is a cyst.
Oh, sorry.
Okay. Dr. Vollmer, any comment?
Yeah, two things. In terms of the arterial phase, what you're really looking for is that there's a nice fat plane around the vessels, and that prior SMA really showed the good black cocoon around the vessel as it comes out towards the valve, really giving you a good assurance that there's no involvement there. Same thing goes for the celiac axis. In terms of the venous phase, two things that I key on are you have to find where the tumor is. I'm a little underwhelmed by this imaging to actually see the tumor. So where I go for that is to follow the ducts to their, from their dilation to where they disappear. And that gives you the area of where it is. In this particular case, the pancreatic duct is not readily dilated or involved with this. And you follow the bile duct down, and it just stops about 1 or 2 cuts below you here. At that point, there is no obvious element of a mass invading the vein, and you're looking for a hypodensity in general. I'm a little underwhelmed by that, but I actually see a little hypervascularity in that place, which makes you think of a neuroendocrine tumor. But that's what you're looking for, the end of the blockage, and then what sort of difference is there between a tumor and the normal parenchyma.
Thank you. Bueno, todos mencionaron que es un tumor pequeño que apenas en realidad o no se ve claramente con la tomografía, se ve una dilatación de la vía biliar franca, se ve completamente libre en la fase arterial y la fase venosa. La tomografía trifásica para tumores pancreáticos es la ideal porque nos da una fase arterial que es la que se mostró primero, en donde se ve completamente libre la arteria mesentérica superior y el tronco celíaco, y la fase venosa es esta, en donde se ve también libre todo el sistema de la vena porta, la unión con la esplénica y la vena mesentérica libre, y apenas si se podría identificar un tumor hacia la casa del páncreas, pero no es claramente visible. Entonces, de tratarse de un tumor maligno, sería un tumor sumamente pequeño que no se ve del todo en esta imagen. So we do not see clearly the tumor here. So what would be the next step at the next imaging study? I think Dr. Rial, she wants an MRI.
Well, I mean, this CT would be adequate. We would have gotten an MRI, but if we couldn't see, yeah, we can get an MRI.
The MRI didn't show any difference in general. It was about the same in this image, and the cholangiography was about the same, just the obstruction of the bile duct, the distal obstruction. But with this, who thinks an endoscopic ultrasound would be of benefit?
So we would get an EUS and biopsy. You know, it's often more sensitive for, you know, picking up the mass in the head of the pancreas. I think this is something that has changed for me over the course of my training and my career. So when I was training, we would have said this is resectable disease. Even if we couldn't see that mass, you know, the CA19-9 is elevated. It's a classic presentation of pancreatic cancer, and we would have been okay going ahead and operating without an EUS and a biopsy. I think what has really changed over time is the use of neoadjuvant therapy and better neoadjuvant therapies. So more and more, even in truly resectable disease, we are treating with neoadjuvant therapy. Certainly neoadjuvant therapy is not controversial and borderline resectable, but for that reason, we would go ahead and get an EUS and biopsy and try to establish a tissue diagnosis.
So this is a point. So Dr. Stein, what do you think of the biopsy and the endoscopic ultrasound on this specific case of a small tumor or not very clear by CT?
Well, I think it depends upon, as Dr. Rial says, your feeling about neoadjuvant therapy. I'm of the opinion that most, even resectable tumors, may benefit from neoadjuvant therapy. And then the question becomes, will your medical oncologist treat patients with neoadjuvant therapy without tissue? If tissue is required for them to treat them, then I think an EUS is a good way to get better visualization and also to establish a diagnosis. If you're a person who believes that resectable tumors should be resectable, I don't think it would be wrong to explore the patient.
Dr. Callery?
I would plan to resect this patient just because I have not fully adopted a clearly resectable patient for neoadjuvant therapy, despite, as Taylor mentions, rising sentiment. So I would move towards operation. Oftentimes these people will come all teed up with an endoscopic ultrasound already. The endoscopic procedure I would be wanting them to have done already would have been biliary stenting to help clear some of this jaundice. So I would move towards a covered metal stent on this patient. And if there were any, let's say, medical comorbidities that precluded moving to the operating room relatively swiftly, then they would have the biopsy for getting tissue diagnosis, as Dr. Stein puts forward, and we can go down either pathway. But we still don't have randomized control level 1 data to support neoadjuvant therapy for resectable pancreatic cancer, despite the improvements in neoadjuvant therapy. So we may get there, but it's still a fully unanswered question. If I could, Carlos, there's a very important point that brought up on the chat, which I'd like to emphasize also earlier, and it had to do with screening. He brought up the very important point of a patient who develops new onset, really escalating diabetes and is otherwise asymptomatic. That's being seen more and more as a flashing light for potential pancreatic cancer. So that's an important point to bring up. Thanks, Steve.
Yeah. Dr. Kent, Tara, so the ultrasound was done and they took a biopsy who revealed what revealed an adenocarcinoma, very small, resectable, vessels free, absolutely. So we had the diagnosis, but this patient was seen in another hospital before she was sent to me. So they did an ERCP. What do you think at this point, if you have the diagnosis, the patient is without invasion, what would you do next after this result of the ultrasound? Would you do an
Mark
ERCP?
and I. Oh, so most of the time, I would like an ERCP most of the time, yes, and particularly in a case where the bilirubin is already at an elevated level as it is in climbing, and depending upon the interval anticipated between evaluation and resection. And I would, in a resectable patient, offer resection unless they're enrolling the patient in a trial.
Dr. Bolmer?
Yes, I'm going to actually counter some of this and say I would take this person directly to the operating room without either intervention. given if I could be guaranteed that there's a mass there on the axial imaging and see it and know it, there is no need to have a biopsy preoperatively, particularly if you're not going the neoadjuvant approach. Secondly, there is no need to be scared of jaundice going to the operating room to a certain level. We had a paper in the last year in the Annals of Surgical Oncology defining a bilirubin level of 13 as being a safety margin for the case you want to have better outcomes from with preoperative jaundice. So in the case of this being 6 and everything else in a healthy person or resectable disease, I'd go directly to the operating room, and I would avoid the last bullet on your slide here of complications from the stent, which have precluded not just a handful of people from ever getting their resection or delaying it.
Okay. Well, they did an ERCP. They put a metal stent, a small cover stent, without any complication. This is the biopsy that I mentioned. We mentioned already about resection versus neoadjuvant treatment. I think we are half and half in the opinion here. But both options are at this point are okay, I think. So we went straight to the operation. We did a pancreatoduodenectomy with a great recovery. We took normally the nasogastric tube. We still use the nasogastric tube. We removed at the first post-op day, early oral nutrition, oral preparation, early drain remodel, and discharge. But here the point of fistula, which I want to emphasize, especially because all of you have a lot of experience with this fistula. We use most of the time external stents, and we measure the amylase every day during 5 days after that. So we have some important papers that we have the privilege to have authors here, like Mark, Charles Vollmer, and Tara, and many others. So please mention a little bit about the risk of a pancreatic fistula. How do you evaluate this risk? And what do you do to avoid fistula in those high-risk patients? Please, all of you, very quick, comment on this. Who wants to start?
Go ahead, Chuck.
So yes, I would use the fistula risk score that you see here in the operating room to make some decisions. You can, and if you could tell me what the nature was of this, I'm saying soft gland, it's a small duct, probably 2 millimeters or 1 millimeter. The blood loss would matter when we have pancreatic cancer. This is probably going to be in a moderate risk zone by that calculus, in which case we would be placing a drain, and we would not likely put an externalized stent, given the nature of this paper you showed here about high-risk cases getting benefit from them only. So, and then I would follow then with the early drain removal based on amylase values in the postoperative period. So I would call this is about 5. If you have very limited blood loss, it's actually a 3 or 4 in the risk, and not so bad, and probably about a 12% risk overall. I would not use octreotide. Our work using risk adjustment with this has actually shown a detrimental or harmful effect in using that, particularly in the more risky glands, paradoxically.
Carlos, it's Mark. We could talk about this for a long time, but maybe it might be best to move on to our liver team now.
Yeah, so this is the amylase. Important to mention that 26 lymph nodes were negative. So this is important for the number or lymphs. So she's ready for adjuvant treatment now. I think the important thing is to get both surgery and chemotherapy. It doesn't matter the order in those very small pancreatic cancer. I think that is one question still to be answered. Well, thank you very much for the invitation. You did great. All of you experts, and thank you, and see you soon again. Thank you very much.
Okay. Thank you, Carlos, and to all the panelists of the Thank you, Carlos, and to all the panelists of the pancreatic cancer case. Let's move on to the liver case. I would like to introduce, I will share very quick my screen. The liver case will be presented by Dr. Jean-Nicolas Bottet. He is the chair of the Department of HPV Surgery at the MD Anderson in Houston. He is the SSAT president-elect and very good friend of Mexico and of the Latin American surgeons. So the group of panelists, el grupo de panelistas que tenemos es un destacado grupo, así también como el doctor, va a ser coordinado por el doctor Bottet. El grupo de panelistas es el doctor Miguel Ángel Mercado he is the chairman of the Department of Surgery at National Institute of Nutrition here in Mexico City, and HPV surgeon and probably the most important surgeon in most of the career of HPV surgeons here in Mexico. Dr. Ulises Rodriguez Wong, he is the president of the AMCAT here in Mexico. He is a colorectal surgeon. Dr. Andan Anseidi, he is from HPV surgeon from San Francisco, the University of San Francisco. Dr. Timothy Paulik, he is the chairman of the Department of Surgery of the Ohio State University in Ohio, and he is the president of the HPVA Association. And Dr. Rohan Jeraba, he is the Chief Department of the HPV Surgery in Methodist Richardson Medical Center in Texas. And Dr. John Fong, he is a professor of surgery and co-director of transplantation surgery in University of Chicago. Dr. John Fong, he is a HPV surgeon and transplant surgeon. So go ahead, Dr. Nicolas Bottet, with your presentation.
Thank you very much. Can you see my slides?
Yes.
Great. Okay. So thank you very much, Eduardo, for leading this wonderful symposium and all these invited speakers, eminent speakers. The case I'm going to present is a case of a 53-year-old gentleman with an obstructive colon cancer at the splenic flexure, who underwent a subtotal colectomy before he presented to us, and he had a T3 and 2A, 2 out of 25 lymph nodes, and presented synchronously with bilateral hepatic metastasis. And the metastases are presented on this slide, and they are really diffusely distributed bilaterally. There is one in segment 3, which is indicated by an arrow in yellow. And this patient received 4-FOX plus bevacizumab for 6 cycles for this advanced disease, presenting synchronously. Of note, he had at least 3 metastases in segment 4, some deeply located. So none of these metastases were peripheral or easy to resect. What would be at your institution the sequence of treatment in this patient at this point? Would you continue the chemotherapy? Would you put markers to localize these metastases at some point before they disappear completely with the chemotherapy? Would you ablate with microwave? Would you do a hepatectomy, right hepatectomy with ablation of the metastasis on the left? Or would you do a hepatectomy in 2 stages? So this is open for discussion. We'll start with maybe Miguel. What would you do? What would be the approach, and how would you proceed with this patient?
Well, good night to everybody. Thank you for the invitation. Well, this is a complex case from the beginning because it's a biologically aggressive tumor. You know, this started synchronic with a lot of metastatic disease in the liver. And so we are dealing with a tumor that is biologically aggressive. It's difficult to decide what to do. I think that the patient received enough chemotherapy. I will suggest to try to do a two-stage hepatectomy, perhaps to try to resect one or each side, resect so many metastases as we can, and then start to do maneuvers to make a hypertrophy of the remnant lobe. Because the other options, I think there's no place. It will be nice to also agree there if one of you will think in a liver transplant, but I don't think so.
Yeah, Dr. Fong, would you consider a liver transplant at this point, since the word transplant is there?
Oh, let's try this. Can you hear me?
Yes, we can.
Okay. No, I think it's too early for transplant. You know, the transplant experience has been very select and been very, have shown really that from resection of the primary to transplant, the longer period of time, 2 to 3 years afterwards, portends better outcomes. So this patient clearly doesn't fit that. There are other factors that we haven't talked about, CEA levels, et cetera, genomics and next generation sequence mutation and mutational analysis. I think right now, either you continue the chemotherapy, you change the chemotherapy, or you go to surgery. I think, you know, some people have talked about using local regional therapies like Y90. I would probably move to either a two-stage hepatectomy or a right hepatectomy, and then come back and do resection. It depends on the functional liver reserve of, you know, the remnants, and so you'd have to do that volumetric analysis. But I think going to surgery at this point probably would be the wise decision.
Okay. In the interest of progression of the case, I will show you the two-stage hepatectomy here. We did the first stage, and we were not sure about the second stage. In fact, two-stage hepatectomy is an ambitious proposition, especially with a patient in whom you resect more than what you think. If you look at the pre-resection left lateral liver, you think the metastasis is very small, but whether you ablate or you resect at the first stage, you find yourself with a remnant that's small, and especially if you subtract the hole you've made in this patient. So this is the risk of such a procedure. It's prohibitive in a patient, even with a normal liver, because it's 13% in this patient. Patient had not had extensive chemotherapy, and it doesn't require 30% in our experience. 25, 20% would be fine. So we are here at a stage where we're going to do a portal vein embolization. And we're thinking about this, but when you do a portal vein embolization, you have to look at your endpoint and what you're doing and what you're trying to achieve. You know, is this going to be enough? Is this going to not be enough? So some papers have reported that looking at the ratio AST to platelet is a predictor of hepatic insufficiency after liver resection. Some have looked at the gradient of hypertrophy, the difference between the post portal vein embolization future liver remnant and the pre-portal vein embolization future liver remnant. The Japanese surgeons have used the endocyanine green, and then in the ARCS literature, particularly, and also in the resection literature now, you find the kinetic growth rate, so the gradient here. So maybe we could discuss these methods of evaluating the liver function before resection in general, and particularly in this case. Maybe Adnan, how would you evaluate this patient response to PV, and how do you evaluate your liver function before resection in general?
Thanks, Dr. Morte. So, you've outlined a nice, the options there. We basically pretty much, as you know, we don't have access to ICG clearance here very well. So the two that we use most is the degree of hypertrophy and the kinetic growth rate. And really the way we use them, we actually end up using both. And the reason why is because, I think it depends on what kind of your background liver. In the situation like this, doing the first stage, we would also have a liver biopsy. So we'll know exactly kind of what are we dealing with. Are we dealing with a liver that has a lot of steatosis or a lot of chemotherapy injury? And, the different livers will react a little differently to PVE. I'd have to say that also in somebody like this, we would consider also using, although it's a little bit outside the norm, using Y90 to the right liver instead of PVE. And then it will take obviously much longer to hypertrophy, but at the same time, if that's the only source of disease left behind, since the left side is cleared, it doesn't really bother us how long it takes because the patient would be off chemotherapy, and at the same time, you'll have hypertrophy of the left side. If we use Y90 to the right side, then the kinetic growth rate is less helpful, and the hypertrophy, degree of hypertrophy is more helpful. But if we use PVE, then we use both to see which one, to see that they both help us in determining when it's safe to proceed to surgery. In that situation, we actually give chemotherapy as well during that time.
Tim, would you comment on the platelet count in these patients? Do you pay attention to the platelet count between liver resection and how do you handle that if you have a borderline platelet count?
I really don't pay that much attention to it in particular. I know that you get hypersplenism and platelet sequestration, if you're cutting off part of the blood supply and getting more shunting that way. But I would agree with Adnan that mostly we're looking at hypertrophy and the kinetic growth rate. And I consider both. Obviously, if I have a liver that grew fast, but it's still pretty small, the FLR is still pretty small, I'm going to be worried. And the same thing goes if I have a big FLR, but it tends to take a little bit longer to get there, I'm going to be less worried. The kinetic growth rate, though, I think for me is very important, right? Because I think it's essentially, this is a stress test for the liver. And, seeing that KGR be sufficient, is really something that I'd like to see. I think since you mentioned it, Nick, I was also wondering, would anyone consider ALPS for this case, since you did throw it out there?
So I think it's going to be after that. It's going to be the third and last question. We won't be too long, but okay. It's coming.
Okay.
So we looked at hepatic insufficiency as an endpoint here, endpoint for the papers we published on the kinetic growth rate. It seems to be predicting pretty good. In and of itself, the peak bilirubin pretty good. The risk of dying from liver failure, hepatic insufficiency, and 1 in 3 patients dies from liver failure if you have a bilirubin that goes up to 7. And I think the number 12, 13 is a bad number. Once you go beyond the 12, 13 peak bilirubin after your liver resection, very high chance of a fatal outcome. So that's a kinetic growth rate. For those who are not familiar with it, it's the difference between FLR post and pre-portal vein embolization, and it's a functional measurement. It's not a static number. as the FLR, but it's a speed of regeneration. So it pretty much tells you about the function and is divided by the number of weeks. So, and this is the kinetic growth rate cutoff of 2%, which has been reported being a good indicator of whether this liver resection is going to be safe. So in this patient, we end up with a liver remnant that's really not increasing, not doing very well with this portal vein embolization of the right portal vein and segment 4. And we have segment 1, 2, and 3, which have increased from 13 to 15% with a KGR of 0.5%. So that's a very, that's a no-go essentially. So the question comes, is, are we gonna do an ALPS? Are we gonna do additional venous embolization? Are we gonna just resort to ablate, or are we gonna complement the portal vein embolization we did with some yttrium-90 in this situation? Rohan, do you want to comment on this?
Yeah, thank you so much. So just a couple of things. First of all, I think that with liver imaging, I do think that MRI is extremely helpful. So for us, we use, and as you know, we published on this, that 30% of our patients with multiple liver lesions from metastatic colorectal cancer will be outnumbered with MRI, with EOVIST, with diffusion weighted imaging. And the lesions that we see are usually less than 1 centimeter in size. So I find this extremely helpful because it complements your intraoperative ultrasound tremendously. The second thing is, I mean, and you guys have written about this, but I think for the world to know the way you do your PVE is also important, because you can't just do coils or particles. You know, glue is often very helpful in these patients with complete stagnation of flow. I just wanted to reiterate what Adnan said too. We're quite fond of Y90 in some of these patients, especially if we're trying to give them a chemo break, because as you know, the PVE is not really protective from a tumor standpoint, but the Y90 is treating that side while you're waiting. Getting to your question. So I think the question here is, I don't have a lot of experience with ALPS, so I'm going to let somebody else who does comment on this. We would probably consider radioembolization to the right liver we don't have much experience, but we are exploring hepatic venous occlusion in these patients too as another modality. So those would be the things to think about. The idea with Y90 is that you're not burning any future bridges. You still have the option to resect or do nothing.
Okay, Dr. Rodriguez Wong, do you in Mexico use ALPS, and what would be your approach?
Buenas noches a todos, gracias por la invitación. Pues es un caso muy interesante donde se ilustran los cambios de criterio que ha habido para el manejo de las metástasis hepáticas. Y precisamente, pues en este caso, en la última etapa para resección, pues hay que aprovechar la capacidad de regeneración latente que tienen las células hepáticas. Entonces, una muy buena opción en este paciente, pues una embolización venosa adicional, o bien la ligadura portal para hepatectomía por etapas, como menciona en la inciso A, para tener un hígado remanente que se regenere aún mejor y tengamos entonces menor riesgo de insuficiencia hepática, que es el gran riesgo que tienen estos pacientes al hacer resecciones en 2 etapas o resecciones muy amplias. Entonces, yo considero que una embolización venosa adicional nos permitiría hacer que el hígado remanente futuro se hipertrofie y entonces tengamos menor posibilidad de insuficiencia hepática en este paciente.
So I think everyone knows the answer here in this case, and we're going to talk about this, the hepatic vein embolization. The 3 major components to the maintenance of the hepatic mass are the portal flow, the hepatic vein outflow, and then unobstructed bile ducts. So if you have impairment of any of the above, you're going to have atrophy, and that's what we tried to achieve in these patients. We did a middle hepatic vein embolization here, you have to be careful with these. You need to leave a sufficient length here at the hepatocaval junction to be able to do your resection that will include the middle hepatic vein and the right hepatic vein. We prefer the middle hepatic vein in some cases because we think in cases you have to do extended hepatectomy, segment 4 is really the segment you don't want to grow. If you do a right hepatic vein, the segment 4 will grow. So that's what we did in this case. And we had a 23% based on this calculation and a 2% KGR. And just show you just 2 slides on this. Here's a paper from France looking at 10 patients who had a complete liver venous deprivation with an FLR less than 25% at presentation, and a nice hypertrophy. There's no KGR reported. If you do a very, very good portal vein embolization, I would be careful about doing both hepatic veins because we've had patients who really are very somnolent after the procedure. And I think if you do a portal vein embolization that's average, it's probably okay to occlude the hepatic vein. And here another paper which presents the kinetic growth rate here and the degree of hypertrophy from Lausanne, Switzerland. But the caveat of this paper is that this patient had liver venous deprivation for an FLR of less than 35%. So it was a very generous use of portal vein embolization, and the numbers look good. The mortality is 0, and I'm not sure it represents the population we are talking about, but certainly it's a feasibility study, and the question is going to be who do you submit to liver venous deprivation with multiple vein embolization. So to conclude, we did the second stage here, and the patient is alive at 7.5 year after the first stage. The full disclosure is that he had, and that's going to please Rohan, he had ablation of a couple more lesions in the left lateral. He had a re-resection at the site of the primary 4 or 5 years after the first stage. But anyway, this is a patient who, in terms of biology, was RAS wild type. So these patients have better survival than patients with RAS mutant. And he was an exceptional patient in terms of biology since he had no mutation. So that's a very, very rare example of a patient who had no somatic mutation. These are the frequency of the somatic mutation, and it's a patient who was very lucky in this regard. Okay, thank you very much for the nice discussion and weighing in, and I will let the esophageal surgeon take over. And Eduardo, thank you very much to the panel for the nice discussion. Thank you.
Thank you. Thank you. Thank you. Bye.
Thank you so much, Dr. Bote, and all panelists for your effort and your friendship. Our next case will be presented by Dr. Samuel Chuflet and Dr. Gabi Alarcon for upper GI case. Thank you so much.
Ya se puede, ya está listo. I'm going to speak in Spanish. I apologize. I'm going to speak in Spanish because most of the listeners are, Spanish speakers. Let me just first give the thanks to all the participants. The topic has been written for some of these participants, the whole history of the paraesophageal hernia, so I'm sure that we're going to listen certain very good key points from them. I'm going to introduce first the Dr. Gaby Alarcón. Dr. Gaby Alarcón is a surgeon in Mexico City. He's part of the ABC Hospital. He works also at the Social Security in Mexico City, and he's part of our chapter. She's the treasury of our chapter. Before I give her the microphone, I want to thank especially to Aurora Pryor, Professor Nat Soper, Professor Carlos Pellegrini, Professor Nathan Sundel, Professor Sammy Clayfinger, that is our vice president of this chapter, Professor Roberto Torres Cisneros, who is the president of the Mexican Society of. I'm sure it's going to be a very nice case presentation, very brief. We try to shorten the movie, the video, so we have a chance to talk the different key points at the end of the movie. Gaby, please.
Sí. Buenas noches a todos. Muchas gracias a todos los participantes. Voy a repasar la siguiente. Acá está. Se trata de una paciente femenino de 83 años de edad con el antecedente de 3 episodios de sangrado del tubo digestivo alto. La primera ocasión fue en el año 2015 y el último evento corresponde al padecimiento actual, que ameritó transfusión sanguínea y hospitalización. También tiene el antecedente de neumonía por aspiración en el año 2017. En cuanto al padecimiento actual, la paciente en los últimos 2 años ha presentado síntomas de reflujo gastroesofágico, tratada con inhibidores de la bomba de protones. Sin embargo, un día previo al ingreso presentó malestar general, náuseas, mareos, sudoración y evacuaciones melénicas. Ingresó con una hemoglobina inicial de 7.2 y un hematocrito de 24. Posterior a la transfusión sanguínea y al tratamiento médico, se efectuó una endoscopía. Los hallazgos de la endoscopía, acá la tenemos. Reportó una gran hernia yatal con coágulos organizados en el fondo y cuerpo del estómago. Después de removerlos, se visualizó un sangrado activo en la mucosa erosionada del estómago herniado. Se dio tratamiento con fulguración con argón plasma. También reportaron úlceras lineares que ya tenían fibrina. En la serie esófago gastroduodenal con vario, vamos acá, reporta una hernia yatal gigante con el fondo y el cuerpo gástrico intratorácico, no reductible y también con reflujo gastroesofágico. Acá es muy evidente. La tomografía. Reporta una herniación supradiafragmática de la unión gastroesofágica, haciendo un efecto de masa desplazando la base del lóbulo pulmonar izquierdo. Por tomografía, sí, por tomografía nos midieron la distancia de los pilares de 40 milímetros. Fue referida al servicio de cirugía. El abordaje vía abdominal por laparoscopía, siguiendo los pasos universales que se recomiendan, que son la reducción del contenido abdominal, la resección del saco, cierre de los pilares, funduplicatura y fijación. Acá vamos a enseñar el video, vemos el defecto herniario. El inicio de la disección fue a nivel del pilar izquierdo. Seccionando los vasos cortos usamos energía ultrasónica. Esto nos va a permitir movilizar y reducir el contenido de la hernia hacia el abdomen. Dividimos el saco del pilar izquierdo, entrando al plano avascular y continuando la disección. Pasamos al lado derecho. Se divide el ligamento gastrohepático y acá podemos ver ya el pilar derecho. Y se hace lo mismo, se divide el saco del pilar derecho para continuar en el plano avascular y seguir con una disección circunferencial del saco. Pasamos del lado derecho a izquierdo o viceversa, dependiendo lo que sea más fácil y más accesible para el cirujano. Vemos acá la pleura izquierda. La disección debe ser muy gentil. Es combinada Roma y con energía ultrasónica. Se continúa la disección y tiene que haber una movilización, para que haya una movilización adecuada del esófago. Ya teniendo el túnel retroesofágico, colocamos un drenaje tipo Penrose que nos va a ayudar a la tracción y continuar la disección. Acá vemos la gran brecha que hay entre los pilares. La clave de esta cirugía es encontrar el plano adecuado. Acá vemos ya la extracción del saco completo. Se afrontan los pilares con puntos separados, anchos. Se empleó Etibond del 2 ceros, que es una sutura no absorbible, con parches de teflón. Se dieron 2 puntos posteriores y también uno anterior. Logramos ver acá un buen segmento de esófago intraabdominal. Se reforzó el cierre con una malla biológica de submucosa de intestino delgado de cerdo. La disposición fue en U. Se fijó la malla con 2 puntos a los pilares. Luego seguimos con el procedimiento de la funduplicatura. Se hizo un Nissen floppy con 3 puntos interrumpidos y también se hizo una gastropexia anterior. Al día siguiente se hizo un esofagograma con material hidrosoluble, el cual muestra que la funduplicatura está en una adecuada posición y no hay fuga del material. Ese día se iniciaron los líquidos claros y a las 48 horas fue egresada la paciente. A los 6 meses se hizo una serie esófago-gastroduodenal con bario, demostrando la posición del estómago intraabdominal, descartando recurrencia.
Vamos a llevar a cabo la discusión del caso y aprovechar, tenemos poco tiempo, por lo cual les pedimos que sean respuestas cortas y vamos a tratar de que todos participen y den su opinión. Me gustaría empezar, voy a traducirle a Nat Soper. Dr. Nat Soper, we're going to start, with quick questions and answers, with looking at the key points. I don't know if you have any question about the case. I think it's a straightforward case. And if you want to have a special comment, Professor Pryor, Carlos Pellegrini, and Professor Sondel, if you want to make a comment about the case, or we just go to some question and answers.
So first of all, the video was outstanding, great technique, and I would do almost exactly the same thing. I had a question as to what type of mesh was used, first of all, because we stopped using the resorbable meshes several years ago because it does not seem to have long-term influence. But otherwise, the question I would have too is she did not have preoperative esophageal manometry and a Nissen fundoplication was performed, I think many surgeons might say that they would have either done no fundoplication or a partial fundoplication under those circumstances. I too tend to go with a Nissen fundoplication in the vast majority of cases. I think it's a much easier operation to do, and if you do it in the correct manner, it should not lead to significant dysphagia.
Thank you, Nat. Profesor Pellegrini, algunos detalles en la técnica, si nos puede usted decir. Ustedes son de los que han escrito, nosotros hemos copiado de ustedes la mayor parte de sus trabajos. ¿Cuáles son los datos que les puede usted aconsejar a la mayor parte de los cirujanos, los datos claves para tener un éxito en la resección del saco herniano?
Bueno, en primer lugar, yo le quiero agradecer por una presentación que es muy elegante, muy bien hecha. Como dijo el doctor Soper, yo creo que nosotros hubiéramos hecho una cosa muy parecida. Generalmente hacemos la manometría preoperatoria para estar seguros de que tenemos un esófago que funciona. Este esófago parecía un poquito dilatado y eso hubiera sido una cosa buena de saber antes de hacer la operación. Con respecto a su pregunta y con respecto a la disección del saco, nosotros vimos que en esta operación que se mostró, quizá por la velocidad con que había que presentarla, que había una disección parcial del lado izquierdo y otra del lado derecho. A nosotros nos gusta generalmente hacer la disección completa del saco, de la parte derecha a la parte izquierda, pasando por la parte más alta, para que se venga todo el saco y con él todo el esófago hacia abajo. Yo creo que esa es la parte más difícil de la operación. Como dijo la doctora, tiene que ser hecha con mucha gentileza. Y la otra cosa que es muy importante cuando se hace esa disección tan alta para traerse todo el saco, es estar seguro de que no se desgarre el esófago, porque hay una tendencia de tomar el saco y tirar el saco hacia abajo para facilitar su extracción. Y a veces el saco puede estar muy unido al esófago y se pueden hacer pequeños desgarros del esófago. Yo hubiera hecho exactamente lo mismo que se hizo. Durante mucho tiempo usamos esa misma malla que ustedes usaron hoy, que es una malla absorbible de la submucosa del cerdo. Nuestros estudios ulteriores demostraron que a pesar de que había un beneficio significativo en un estudio randomizado inicial con el uso de la malla, con el tiempo, más de 3 años, se erosionaba ese beneficio y era lo mismo hacer con malla que sin malla. Los puntos que se dieron me parecieron excelentes, tienen que ser grandes, tienen que ser con un material de por lo menos 2 ceros y el uso de los pledges me pareció muy interesante también y muy bueno.
Dr. Ployer, Aurora, one question. Do you have any suggestion in the technique to take the sac and the way that you repair the crura?
Yeah, so excellent presentation and congratulations on this. In terms of the closure, if things come together nicely like they did on this case, then I don't necessarily think you need reinforcement, as Dr. Soper mentioned. If the tissue's nice and it comes together well, I'll just do a primary repair. Now, if it's not coming together nicely, I think you need to employ things like relaxing incisions in the diaphragm where you can bring the native tissue over, and then you'll use a mesh to fill in the gap in that relaxing incision. Or I've started doing something lately with the falciform flap where you can bring in actually native tissue of the falciform ligament and bring that in to reinforce or repair if it doesn't look nice. So those are some of the things I think are worth considering.
Thank you, Aurora. Una pregunta para todos en una forma concisa. Hay muchas formas de cerrar los pilares, puntos interrumpidos, sutura barbada, puntos continuos, el tipo de material que usan, los que usan con parches de teflón, sin parches de teflón, los que usan parches, los que usan de alguna manera parches ya sea absorbibles o inabsorbibles. Queremos la opinión en términos generales, cada uno de ustedes, cómo lo hace. Let me just translate to Nat and Aurora. Which way you repair the hiatus? Normally, let's take like a case like this that comes nicely. Which type of suture you should continuous suture, interrupted sutures, which material, which one. I know that there is, Nat and Carlos are the one who wrote the article using the CIS. So I know that they still use them, and I know that the long range doesn't work. But many of these patients, this is an 84-year-old lady, she probably, I don't know, I hope she lives for 120, but usually the life expectancy is short. So it's valid to use this graft, this type of absorbable graft. Go ahead, please.
Sí. Hola, buenas noches.
Adelante.
Hola, buenas noches.
¿Qué tal, Robert?
Sí, perdón, no sé para quién iba la pregunta, pero
para todos.
Aprovecho para responder. Creo que es un buen caso y está muy bien operado y creo que es una buena disección. Aquí lo más difícil es hacer la disección lo más alto posible hasta llegar a un punto donde baje el esófago. Y en los cierres de los pilares, bueno, digo 2 puntos arriba, o 2 puntos abajo y 2 puntos a 1 punto arriba. Creo que yo daría un poco más de puntos. Lo que sí haría yo, sin duda, en este tipo de hernias, es una endoscopía transoperatoria al final de la disección. No sé qué piense el doctor Pellegrini de la endoscopía transoperatoria.
The question for all of you is necessary to use an endoscopy after you do the wrap.
Él me preguntó qué pensaba y la respuesta mía es que yo creo que es siempre una buena idea. Nosotros hacemos una endoscopía intraoperatoria a todos los pacientes cuando terminamos la operación del esófago, cualquier operación que sea.
Déjeme modificar un poquito la pregunta, doctor Pellegrini. El problema en nuestro país y casi toda Latinoamérica es que los cirujanos no hacemos la endoscopía y hay que llamar a un endoscopista. Si uno tiene una buena reparación, ¿hace falta que llamemos al endoscopista?
No, yo creo que tiene que hacerlo el cirujano porque el cirujano quiere hacer una endoscopía para ver cosas que son pertinentes a la cirugía. Cómo aparece el wrap, cómo aparece la sutura, hay alguna perforación, hay algún otro problema. Es un problema quirúrgico. Y yo creo que tenemos que entrenar a todos los cirujanos para que los cirujanos la hagan intraoperatoriamente.
Sí, de acuerdo.
Adelante. Nat.
What is the question, Samuel?
The question is, the way that you repair the hiatus, what type of suture you use? Is valid to use continuous suture, interrupted sutures? You use certain reinforcement or you don't?
Right. So for a run-of-the-mill case, I think there are a number of things you need to do to decrease the tension at the hiatus when you're getting ready to close the crura. That is, decrease the pressure of the pneumoperitoneum. Make sure you divide any adhesions that are going to the edges of the hiatus. And then I generally use interrupted sutures of heavy braided permanent suture. I usually do not reinforce that with any kind of mesh. If you cannot bring the tissue together without significant tension, and one of the ways that I assess that actually is by always doing intracorporeal knots. And if you have trouble getting your knots down, you know there's too much tension. I then do a relaxing incision, as Dr. Pryor was speaking about, almost always to the right side of the hiatus. It ends up being near the vena cava frequently and being a little bit scary, but you can usually open that nicely and bring the crura together without any tension at all, primarily, and then put a piece of mesh away from the esophagus. So I never now put a permanent polypropylene mesh or something like that at the hiatus for fear of causing later problems.
Now you answer a certain thing, and I want to complete the same question. Which one of you use relaxing incision? Which one of you measure the tension for the closure? Or do you have any experience at Duke, at Northwestern or Washington U, measuring the pressure to feel if you are suturing with tension? And one question more, including to that, what's your opinion as a relaxing incision to do a pneumothorax, no, to open the left pleural space to relax the diaphragm. We don't use it in Mexico, and I'm sure that more of Latin America know, but I would like the opinion of the all of you. But it's open to everyone, the question. Professor Pellegrini.
So I'll do the relaxing incision, just how Nat described it. I've not done the pneumothorax, at least intentionally, but I have talked to people who think it's very helpful. So I think if I have trouble closing and I'm not happy with the closure, I think that's something I'll employ on my next really tough case.
And you patch the relaxing incision?
So in general, I don't use a mesh at all unless I have to do the relaxing incision, and then I'll use a mesh.
Okay. Professor Pellegrini?
And that's the same approach. I would use a relaxing incision on the right side. A pneumothorax is not a problem during laparoscopy. You can injure the pleura in many areas. You just close the pleura, and that's the end of it. It's not a big problem. And if it is a big problem, the only problem is to recognize that you have it and treat it. But in general, during paraesophageal hernias, we open the pleura very often on the one side or the other when we're trying to dissect the sac. So.
Una pregunta es de cuando ustedes abren la pleura para relajar, también se relaja en forma importante el diafragma izquierdo. En términos generales es algo que preocupa. ¿Tienen algún problema posoperatorio en estos casos, aunque sean grandes, abiertas, y no manejar sin tubo de tórax, etcétera, en estos pacientes? Let me translate the question to Dr. Pryor and Dr. Ken. When you open the pleura, either to relax or accidentally, do you do anything to expand the lung, the post-op, or you just expand during anesthesia and not do anything after?
So I don't do anything, frankly. At the end of the case, I'll take the suction tube that I have, the suction one, put it up through the hiatus into the mediastinum, and when we are exsufflating, getting the carbon dioxide out, I'll just put that on low suction to try and suck as much air and whatever else out of the pleura. I do not close the hole in the pleura. I think that's often very difficult, and the pleura can be very thin and rip and things. I don't think you need to do that. So I do try to suck out as much CO2 from the mediastinum as possible. The vast majority of the time, the patients don't have any instability at all as a result of the pneumoperitoneum, but I always tell the anesthesiologist that I have created a pneumoperitoneum when I know I have, because sometimes they will drop their pressure, and I want them to be aware that that has taken place. I've only had literally one patient in my career where I had to put a chest tube in intraoperatively, and that was in my first 20 cases. Probably would not do it now. If anything, I think it becomes a problem if there's a very small hole and you don't recognize it, and it can ball valve and develop pressure in the pleural space. If anything, then if you have trouble, I say make the opening bigger so you equalize pressure between the abdominal and the thoracic compartment, and then you can decrease the pressure, exsufflate, increase the ventilation parameters. And again, I've never had a major problem after creating a pneumoperitoneum, either purposefully or accidentally.
Natán Sundel, ¿cómo manejan ustedes en los casos que estás trabajando el hiato y se produce un pneumotórax? ¿Haces lo mismo, nomás expandes el pulmón o haces alguna otra maniobra?
Primero saludar a todo el mundo, excelente video y excelente idea a todos ustedes por hacer esto. I hope you learn a lot through the Zoom contact, because I'm surrounded with very good friends and very smart people, so maybe I will learn something. Lo primero, yo no volví a poner mallas, a menos que sea una de esas hernias circulares grandes, las que tienen otros shapes, sutura barbada continua con un par de puntos separados, y no hemos vuelto a tener mucho problema con eso. Incisión de relajación siempre, y I want to know why Nat does it in the right side. I do it always in the left side. I will want to understand why you do that, so I can learn why to do that. The pleura opens from time to time. I don't do anything. I mean, I never close the hole. I put chest tubes at the beginning. I don't put any chest tubes anymore. No volví a poner tubos y no cierro nunca el orificio de la pleura. Nunca hemos tenido problemas con eso. También reseco todo el saco, como comentó el doctor Pellegrini, pienso que es importante, pero le presto mucha atención a la forma del hiato. Si es una forma más como heart-shaped, la mayoría no tienen problema. Las circulares, puras circulares, I do a lateral incision to relax.
Dr. Kane, do you want to make a comment? I think she's not listening to me. It's okay. Aquí, another next key point, and one of the most important things is the technical way, the more simple way to advise the general surgeon how you fix the wrap and how you fix it. Everybody agree that you have to fix in certain way. This is been for 5 or 6 decades that everybody want to fix it, you know, either the left curvature, either the fondos, either, you know, posterior fixation with a lot of modification and a lot of techniques. Which one is the easy way? Profesor Pellegrini, ¿cuál es la forma más fácil que le recomienda a todos para fijar el wrap una vez que se hizo la fundoplicatura? ¿Hacerlo posterior, anterior? ¿Hace diferencia?
Yo no creo que haya ninguna diferencia mayor. Yo lo fijaba siempre el tope del wrap, la parte más alta, al pilar derecho, al pilar izquierdo, a los dos juntos, un punto de un lado, un punto del otro, poner un punto posterior si se puede, para que tuviéramos un estómago que está contenido en esa zona. Pero no creo que haya ninguna diferencia con ninguna técnica y francamente no creo que haya mayor diferencia si no lo fija tampoco. Yo lo he fijado siempre por tranquilidad.
Okay. Dr. Matt Chopper, there's any difference when you fix the wrap, you know, to keep it in the below the diaphragm? The same for you, Dr. Pryor?
So the vast majority of the time, I actually do not connect the fundoplication to the diaphragm. When you do fluoroscopy, you can see that the esophagus moves separate from the diaphragm. And if you now bring them together and they have a sneezing episode or a coughing episode or something, I can imagine that actually ripping apart the fundoplication. So I usually do not do anything in terms of fixing the fundoplication. In people who have had a totally upside down stomach, a complete volvulus, I often will fix the distal stomach to the anterior abdominal wall to help prevent a recurrent volvulus, even intra-abdominally. But otherwise, no, I don't. I prefer Nissen fundoplications, and I usually use 3 stitches. At least one of them is fixed to the esophagus. And I use, again, heavy braided non-absorbable suture.
How about you, Dr. Pryor?
On both Nissen and Toupee, I'll do a posterior gastropexy between the fundoplication and the diaphragm closure. I think that's a nice way to anchor the wrap and not actually have it as part of the swallowing dynamic. For a Toupee, my top stitch on both sides will be anchored to the diaphragm.
Okay. Sammy Cliffinger, ¿fijas tú el estómago posterior, anterior? ¿No lo fijas?
Lo fijamos y le damos un punto en la parte, como dice el doctor Pellegrini, en la parte más arriba de la fundoplicatura al pilar del lado derecho. Y regresando un poco al comentario, es importante respetar el peritoneo de los pilares diafragmáticos una vez que disecamos el saco con mucho cuidado, porque si no, a la hora de cerrar los pilares se pueden abrir con facilidad. Igual no hay ninguna diferencia, en realidad son 3 puntos y uno más fijado al pilar del lado derecho.
Roberto, ¿alguna sugerencia distinta o igual?
No, casi nunca fijo la fundoplicatura en los pilares. Creo que no es necesario, la movilidad es separada, entonces no fijo. Es excepcional que tenga que fijarlo. Lo fijo solamente cuando siento que hay mucha tracción, pero prácticamente...
Bueno, para seguir más controversia, yo soy como el doctor Pellegrini, lo fijo atrás, lo fijo de un lado y lo fijo del otro, para que quede bien amarradito y estar contento de verlo ahí.
Esa parte del diafragma no se mueve.
Excuse me.
Esa parte del diafragma no se mueve. Seguro,
porque es uno, y además si no, pues lo fija uno hasta donde la raíz, donde nacen los pilares, ¿no? When we are talking in Spanish, for you, we have differences. We fix the wrap, and we don't think make any difference because we go all the way back to the crura. So that area doesn't really move, So I don't think that make too much of a difference. But this is one of the key points of controversy, and that's why the whole group is divided. Some yes, some no, some on the left, some on the right, some posterior. But one thing that is definitive, if you don't, there is a lot of papers that show that if you fix the wrap posteriorly, the difference in recurrence is quite important. But anyway, that will be for our next Congress in Acapulco, in Puerto Vallarta, that we're going to invite all of you. And, we don't have enough time. There is only one last question that Sondel and Dr. Pryor. We are very upset in general surgery to close all the holes. We use an 11, the 11 trocar, we close them all the time. And I know that you in bariatric surgery, you leave all the holes open. What's your opinion, Dr. Pryor and Nathan?
So the larger the incision, the more chance there is of a hernia. So for the bigger trocars, I think, particularly in a hernia former, you should close it. So if I'm doing a hiatal hernia repair, I will close that 12 millimeter trocar site.
Nathan?
I will say now with the COVID thing, it's even more important what you do, because in the past we used to close the holes with all the CO2 coming out from the patient. We cannot do that anymore. So once you collapse and remove all the CO2, our bariatric patient, nobody's gonna close that ever. So either you have one of the trocars that you put the suture since the beginning, that there are some trocars that they can do that, or you close it at the end. In bariatric, for that, we learned that we put our trocar in a position that we usually don't close it, unless you need to distend a lot to remove the stomach or something like that. So I agree with Aurora. We try to prevent that to happen.
Thank you so much to all of you. And Professor Pellegrini, muchísimas gracias. Nat, thanks to you. You did a nice job, and now we are together, and we hope that we will have a lot of webinars together. Dr. Pryor, thank you very much. Dr. Ken, Dr. Sunder, Roberto, Sammy, thank you so much for all of you.
Thank you. Thank you very much, Dr. Gaby Alarcón. Let's move for the final remarks for our secretary, Dr. Enrique Stoppen, and just a few words from Mark Callery to close this excellent webinar.
Thank you very much. And I do want to emphasize this big effort made for many of us with this new method of connecting online, which has been for many of us different and a little bit difficult, but however, it's been highly successful. And for tonight, I do want to thank very much for this pancreatic cancer in case 1, Dr. Chan and Dr. Vollmer, Dr. Stain, Dr. Callery, Dr. Ryan, Dr. Kent, for such a convincing chat that you've given to us, all of us. In case 2, with this multifocal liver metastasis, Dr. Buttery, Dr. Mercado, Dr. Pollack, Dr. Al-Saidi, Dr. Rodriguez Wong, Dr. Jejeraha, and Dr. Fong, thank you very much for it. It's been very, very positive and influential for all of us. And well, with a potent and graphical explanation with this video, Dr. Kleinfinger, Dr. Pellegrini, Dr. Soper, Dr. Torres Cisneros, Dr. Sundel, Dr. Pryor, and of course, Dr. Schusleb with this giant periesophageal hernia. Thank you very much. It is very fortunate that we have this partnership with the SSAT now in Mexico and whole of Latin America. During this webinar, we've had over 450 participants online from many parts of the world. And we do invite you to, as Dr. Schusleb said, we do invite you for next year's 2021 Clinical Congress in Puerto Vallarta. Hopefully, we will have a new normality, and hopefully, we will have a presential clinical congress. And I am very pleased to announce that we will also be, the SSAT chapter in Mexico will be present in this National Clinical Surgery Clinical Congress this year. We will be participating there. So for all of you, I just want to thank you very much. It's been highly successful, and just my best wishes. I hope to see you soon. Stay safe, stay healthy.
Dr. Callery, the final message to all the audience as a president of the Art Society, please.
Yes, thank you very much. Actually, I had enough to say earlier. I'd like to defer to the chair of our Board of Trustees and past President, Dr. Stain, to close the evening. Stephen?
Well, I just want to thank all the participants, especially Sam, Dr. Montalvo, Dr. Jones, and everyone who participated. This has been a great kickoff for our international program, and I think we have great things to come in the future. I appreciate it. Thank you very much. And everyone, please have a good night.
That's thanks to you.
Good night, everybody.
Thank you so much. Gracias.